Welcome to VetSciCast, the veterinary podcast validated by vets with the help of AI. Welcome to today's new episode.
Today, we're not just reading guidelines. We're really confronting what amounts to years of clinical habit. We're drilling into the 2018 ACVM consensus statement because it forces us to, retire that routine, almost reflexive, prophylactic use of GI protectants in small animal medicine.
It is absolutely crucial. And for our audience, we all know these drugs work for treating, say, gastroduodenal ulceration and erosion or erosive esophagitis. That's not the debate.
Right.
The mission of this deep dive isn't to question their efficacy, but to really define the evidence-based threshold for when to prescribe them, because the widespread inappropriate use is, well, it's documented and the risks are no longer debatable.
Okay, let's unpack this immediately. I think we should start with the failure points. Before we can define when to use a drug, we have to understand the PK/PD that dictates why one is superior to another. So let's start with the histamine type 2 receptor antagonists, the H2RAs.
The big limitation there is pharmacological tolerance, tachyphylaxis.
And that's the real deal breaker for any kind of chronic management, isn't it?
It is. H2RAs are competitive inhibitors, and, well, the consensus data shows the body just compensates aggressively and rapidly.
I think we all picture that compensation taking weeks, but how quick is rapid in the data they actually reviewed?
It's alarmingly quick. In dogs, tolerance can start to manifest within 3 days. It's clearly documented inside of 13 days of continuous administration.
3 days.
And for cats, the data they cite on phenotidine shows a 60% decrease in the mean percentage time that the intragastric pH was kept above 3.0. And that's just between day 1 and day 13.
So you lose the majority of your therapeutic effect in under 2 weeks.
Exactly. It's a massive functional failure.
So what's the mechanism there? Is the body just getting better at clearing the drug or something?
No, it's a biological compensation loop. When you block that H2 receptor, you disrupt the normal feedback, and that leads to hypergastrinemia. And this elevated gastrin, it's a powerful trophic factor. It causes the enterochromaffin-like cells, the ECL cells, to upregulate their synthesis of histamine.
So you're just producing so much histamine that it floods the system and overwhelms the
competitive blockade. The H2RA just can't keep up.
So the body doesn't just compensate, it actively, overbuilds the very system you're trying to block. That insight alone immediately drives us to the alternative, the PPIs. If H2RAs fail because of that compensation, the only way forward is to target the final common pathway, the proton pump itself.
Exactly. The PPIs, these substituted benzimidazole drugs, they target that pump irreversibly. But here is the critical point the consensus demands we fix in practice.
Okay.
PPIs must be administered twice daily, BID, to meet any real therapeutic goals for serious acid-related disease.
So we're moving beyond SID dosing entirely for GE management. Why is BID so non-negotiable? What's the therapeutic target we're aiming for that SID just can't hit?
It's about sustained acid suppression. For healing erosive esophagitis, the goal is maintaining an intragastric pH of greater than or equal to 4.0 for at least 16 hours a day.
16 hours.
And for duodenal ulcers, it's even stricter, greater than or equal to 3.0 for 18 to 20 hours per day. The consensus confirms that once daily administration just gives you transient suppression. It fails to sustain that necessary mean percentage time above those thresholds.
Which means if a patient comes in with confirmed GUE and we send them home on once daily omeprazole, we're effectively, compromised mucosal healing, even though we picked the superior drug.
Precisely. You only get maximal inhibitory effect after about 2 to 4 days. And that's because the PPI only binds to actively secreting parietal cells. You need that repeated BD dosing to inactivate the newly synthesized pumps as they come online.
SID just doesn't provide the coverage.
Not for GUE, no.
Okay, so if BID is required for efficacy, that also means a greater duration of exposure to potential adverse effects. Let's talk about the PK/PD traps that put more pressure on us to restrict prophylactic use. First one, rebound acid hypersecretion, RAH.
RAH is a major clinical concern, especially after you abruptly stop prolonged PPI use. And we're talking treatment longer than, say, 3 to 4 weeks.
And this goes back to that hypergastrinemia we were talking about.
It does. That doesn't just stop. It drives parietal cell mass expansion. So when you suddenly remove that irreversible blockade, that hyperstimulated expanded cell mass causes a massive symptomatic gastric acid hypersecretion.
That rebound must be just awful for the animal. For the DVM listening, what's the biggest mistake we're making when trying to pull a patient off long-term PPIs?
Stopping them cold turkey, it's the worst thing you can do. The consensus is explicit here. You need a gradual taper, something like a 50% dose decrease weekly, and you start by stopping the evening dose first. It lets the system downregulate more gradually.
Okay, beyond RAH, there's this growing concern about the impact on the gut itself, specifically intestinal dysbiosis.
This is where it gets really interesting, because the effect on the small intestine seems to be independent of acid suppression.
What do you mean?
Well, we prescribe PPIs to mitigate upper GI injury from NSAIDs, right? But by chronically suppressing acid and altering the microbiome, we can actually increase the risk of NSAID-induced small intestinal injury.
Because that decreased acid barrier lets unwanted bacteria proliferate, which then compound the damage from the NSAID's interhepatic recycling.
Exactly that. It creates a therapeutic paradox, and it really forces you to question our combined protocols. It's a critical reminder that these drugs are not benign.
And we can't forget the drug-drug interactions. Increased gastric pH messes with the absorption of weak bases, like azurial antifungals, ketoconazole, itraconazole, and it interferes with iron uptake.
All important considerations.
This brings us to the absolute crux of the 2018 statement: restricting prophylactic use. I mean, this document just ripped up decades of assumptions about when to prescribe these. So what is the evidence-based threshold for saying no in these common scenarios?
The threshold is pretty simple, actually. A documented or at least highly probable acid-related injury or active GI bleeding. The consensus targets 3 extremely common situations where prophylaxis is just, routinely practiced without any real evidence.
Okay, number 1, non-erosive gastritis. I still see a lot of DVMs prescribing an acid suppressant when an animal is vomiting, sort of treating it as an antiemetic.
The consensus on this is absolute. There is 0 evidence to support prophylactic use of gastroprotectants in dogs and cats with non-erosive gastritis. Vomiting is a motility issue or it's a central issue.
So treat it with antiemetics.
Treat it with antiemetics, not acid suppression. Using these drugs when there's no ulceration is just applying all of the risk with no documented benefit.
Okay, let's move to pancreatitis. The classic knee-jerk reaction, especially in critical care, is to reach for a GI protectant in any severe inflammatory state like pancreatitis.
Yes, but despite that high acuity setting, the consensus finds no evidence that acid suppression is beneficial or indicated in managing pancreatitis in dogs or cats. That is, unless that animal has concurrent, confirmed GUE.
So any mucosal failure is more likely from hypoperfusion, not primary acid hypersecretion that needs a systemic blockade.
That's the thinking. That practice really needs to stop.
That is a huge practice-changing takeaway. Okay, finally, chronic kidney disease. CKD has historically been a default indication. We've all done it. And IR stage 2 comes in, we throw an H2RA at them just in case of uremic gastropathy. What did the consensus find that really tore up that old assumption?
They found that GUE is simply not a typical finding in dogs and cats with early-stage renal disease. Studies showed no significant difference in gastric pH compared to healthy controls.
So it just refutes that whole hyperacidity hypothesis in early disease.
It does. And because of that, the consensus states there is no evidence to support prophylactic use in dogs and cats with IR stages 1 through 3 renal disease.
And why the particular warning about using PPIs in all CKD patients, even those without GI signs?
It's because of the potential for deleterious effects on calcium metabolism and bone remodeling. We know there's a link in at-risk humans between chronic PPI use and osteoporosis.
Right.
So when you consider how many cats with moderate to severe CKD also have renal secondary hyperparathyroidism, introducing a drug that might worsen calcium or bone density is an extreme risk. You would only advise it if there's severe GI bleeding.
And just briefly, what about high-dose glucocorticoid administration, like for spinal cord injury? Is prophylactic use justified there?
No convincing evidence at all. The consensus is clear. No evidence that traditional gastroprotectants, PPIs, H2RAs, or even misoprostol are beneficial for preventing GI complications from high-dose steroids.
So with prophylaxis largely out for these conditions, let's just confirm the standard of care for confirmed GUE. Where do the secondary agents, like sucralfate, fit into this new restricted framework?
For confirmed GUE or erosive esophagitis, the BID-administered PPI is the standard of care. It's superior to H2RAs, sucralfate, misoprostol, everything for treating acid-related disease. Sucralfate's role is really just supportive. It's cytoprotective. It forms a complex with protein in damaged mucosa.
But does it give you an added benefit when you combine it with a PPI?
The consensus found no evidence to support a therapeutic benefit when combining sucralfate with either a PPI or an H2RA for GUE treatment. And clinically, it's worth remembering that, due to shorter transit times in dogs, intact sucralfate tablets might not even fully disintegrate.
So a liquid suspension would be better for topical effect.
Potentially, yes.
And the most niche drug of all, misoprostol.
Misoprostol, the prostaglandin E1 analog that's reserved for one very specific evidence-based niche. It's effective for decreasing gastric lesions in dogs treated specifically with high-dose aspirin.
And that's it.
That's its defined role. There's a lack of evidence for preventing GUE from other NSAIDs or from glucocorticoids.
So if we synthesize all of this, the 2018 ACVM consensus is demanding we transition from this habitual low-evidence prescribing to a judicious, evidence-based application. We now know the PK/PD flaws of H2RAs and the absolute necessity of BiD dosing for PPIs to hit those acid suppression goals.
And that the vast majority of these non-ulcerative conditions, pancreatitis, early CKD, non-erosive gastritis, they just don't meet the clinical threshold for prescription.
This demands we shift our thinking entirely. We have to be acutely aware of the iatrogenic harm, especially that intestinal dysbiosis, which can ironically increase vulnerability to NSAID injury even while we're suppressing gastric acid.
Right. The focus has to be on maximizing therapeutic efficacy against true acid-related disorders while rigorously minimizing risk for the patients who simply don't need these drugs.
If you connect this to the bigger picture, the entire statement seems to be a challenge to our reliance on human extrapolation. It's pushing us toward truly targeted small animal research that respects these very strict therapeutic endpoints.
Absolutely. Those well-defined endpoints, like the MPT pH greater than or equal to 4.0 for 16 hours, they just highlight the gap in our current knowledge. We have to continue researching and defining optimal dosage, timing, product selection, especially with newer generation, longer-acting PPIs or delayed release formulations. The core challenge for the future is moving beyond simple habit and finding the most effective, targeted way to manage gastric health without causing undue harm.